All right, everyone, welcome back to the deep dive. So glad you're joining us. You know how this goes. We take a stack of info, your sources, your notes, and really get into it, pull out those must-knows. Today, our mission is super specific, really high-yield stuff. We're distilling some targeted revision notes on, well, a pretty common but sometimes complex topic. We want to give you the essentials, make it clear, memorable, perfect for revision or just, getting a better handle on it. The topic. Premenstrual syndrome or PMS?
Exactly. And the source material we're using is laser focused on PMS, laying out the key things you need to grasp. Think of this as us unpacking that structured knowledge from the notes, turning it into a conversation that hopefully helps it stick.
Yeah, consider this your fast track to understanding PMS straight from these specific notes. If you're revising, perfect. Curious, you'll learn a ton quickly. Okay, let's dive in. Where else to start but the definition, right? What is PMS according to these notes?
Right, so the notes define it as a combination of physical and emotional symptoms. Pretty straightforward start. But the absolute key thing, the really critical point from these notes is the timing.
Okay, timing.
These symptoms occur strictly in the luteal phase of the menstrual cycle.
Right, after ovulation.
Exactly, that second half of the cycle.
Yeah.
And just as crucially, they resolve, they go away with the onset of menstruation or, very shortly after it starts.
That timing sounds like the absolute bedrock then.
It really is, according to the source. That pattern is essential for the definition and diagnosis. And the notes emphasize this isn't always just minor stuff. PMS can significantly affect a person's well-being, their quality of life. Oh, and another important point they make.
Mhm.
It occurs only in ovulatory cycles,
Oh, okay.
which means logically you wouldn't see it before puberty, during pregnancy, or after menopause, because ovulation generally isn't happening then.
That timing piece really does frame it, doesn't it? It's not constant, it's tied to that cycle. Symptoms during the luteal phase, gone with the period. That's the core message. And the notes list quite a few common symptoms, covering, well, both mind and body. Things like anxiety, irritability, feeling down, mood swings, sleep problems, fatigue, changes in sex drive.
And physical ones too.
Yeah, breast tenderness, weight gain, headaches, appetite changes, aches, bloating. It's a real mix, paints a picture of how varied it can be.
It really does. And the source also mentions a more severe subtype, premenstrual dysphoric disorder, PMDD.
Right, PMDD.
Yes, share some features, but the notes highlight it has particularly distinct, often quite debilitating psychological symptoms that are more prominent.
Okay, so that's the what. Now, what about the why? The etiology, the causes, what do the notes say?
Well, the first thing the notes state quite clearly is that the exact cause,
It's unknown.
still unknown, but they detail factors that are thought to be involved. The main focus seems to be on hormonal changes.
Right, the cycle hormones.
Exactly, those fluctuations in estrogen and progesterone during the luteal phase, and maybe how sensitive someone's body is to those changes. Serotonin levels are also mentioned as potentially playing a role, that interaction between hormones and brain chemistry.
Okay, so hormones and serotonin interactions.
Yeah, those seem to be the main suspects according to the notes. They also list other potential contributors like broader neurotransmitter imbalances, maybe some genetic predisposition, and lifestyle factors too.
So the takeaway from the notes is it's complex, no single smoking gun, but it seems centered on that interplay between the hormonal cycle and maybe neurochemical sensitivity, particularly serotonin.
That sums it up well based on this source. It's about biological sensitivity and interaction.
All right, let's shift to something always useful for revision, risk factors. The notes have a solid list here, helping you spot who might be more susceptible. This feels like really high-yield info.
It is. The source lists specific factors that seem to increase the likelihood. Let's run through them. First, a personal or family history of PMS itself suggests a possible genetic link or shared environment.
Makes sense.
Then, a personal or family history of mood disorders like depression or anxiety.
Okay, a link to mood vulnerability.
Age is a factor, typically women in their reproductive years, which fits with the need for ovulatory cycles.
Right.
Stress is lifted. Makes sense. Stress impacts everything. A history of trauma is mentioned specifically, including sexual abuse. That's an important one.
Definitely.
A sedentary lifestyle. Those hormonal and neurochemical factors we just talked about, they're kind of risk factors in themselves, indicating sensitivity.
Oh, yeah.
Cigarette smoking,
Mm-hmm.
alcohol intake,
Uh-huh.
and also weight gain is listed as a potential risk factor.
Wow, that's quite a list from the notes. If you're trying to memorize these, maybe grouping them could help. Like history and genetics.
Mhm.
Then psychological factors like mood disorders and trauma, lifestyle things like exercise, smoking, alcohol. and then the underlying biology. Breaks it down a bit.
That's a great way to think about it, yeah. Create those mental buckets.
Okay, and pathophysiology, how does that connect? Does it add much beyond the causes?
It circles back mostly,
Huh.
reinforcing the main points. The notes basically reiterate that the mechanisms involve those hormonal fluctuations, estrogen, progesterone, and their interaction with serotonin pathways.
So, same players involved.
Pretty much. And again, the source emphasizes that the exact mechanisms are complex and, well, not fully understood yet.
So it really just reinforces that link between the etiology and where the biological action seems to be happening, those hormonal and neurochemical systems responding cyclically. It connects the what to the where based on the notes.
Absolutely. Now, this next bit is critical, both clinically and for revision. Differential diagnosis.
Ah, yes, the what else could it be?
Yeah.
List, always important.
Crucial. The notes list other conditions that can present with similar symptoms. Getting this right avoids misdiagnosis, and it's quite a list they provide. Things to consider include mood disorders, definitely, depression, anxiety, panic disorders.
Okay, the psych overlap.
Endocrine issues. Hypothyroidism is a big one. Can cause fatigue, mood changes, anemia of various types, iron deficiency, B12, folate deficiency. Again, fatigue is a common symptom.
Right.
Then gynecological conditions like dysmenorrhea, that's painful periods, or endometriosis, GI stuff like irritable bowel syndrome, IBS, urinary issues like interstitial cystitis, chronic fatigue syndrome, fibromyalgia, that widespread pain condition,
Wow.
and even autoimmune conditions like SLE, systemic lupus erythematosus.
Goodness. Looking at that list from the notes, it spans everything. Mood, hormones, blood, gut, gynae, pain syndromes, autoimmune. It really hammers home why you need a careful history and evaluation. It's clearly not always PMS. That's a vital list to keep in mind from this source.
Definitely. Thoroughness is key.
So how common actually is PMS? What do the notes say about epidemiology?
Okay, prevalence. For the UK, the source states PMS affects a pretty significant chunk, 30 to 40% of reproductive age women.
30 to 40%. That's quite high.
It is. But the notes also stress that severity and how people experience it varies a lot. And here's a really important distinction the notes make. They say around 95% of reproductive age women experience some premenstrual symptoms.
95%. So almost everyone.
Experiences something, yeah. But only about 5% of these women have symptoms severe enough to actually meet the criteria for PMS or the more severe PMDD.
Ah, okay. So experiencing a symptom is super common, but the full syndrome is less so, maybe around that 5% mark of all reproductive age women having significant PMS, PMDD.
That seems to be the implication, yes. Still a significant number, but clarifies the difference between common symptoms and the clinical syndrome. And for PMDD specifically, the notes give a prevalence of about 1.8 to 5.8% among menstruating women.
That's really useful context from the notes. Very common to have some symptoms, but the actual diagnosed syndrome, especially the severe form, affects a smaller but still important group. It clarifies that distinction nicely.
So let's talk about what it actually looks like day to day. Clinical presentation. How does it show up, according to the notes?
Right, the signs and symptoms.
Well, it's that mix we talked about: physical, emotional, behavioral symptoms. And again, the notes really drive this home. The timing is key. Symptoms in the luteal phase, improving or resolving with menstruation.
Can't emphasize that timing enough, it seems.
Apparently not. Common examples reinforced in the notes are things like mood swings, irritability, bloating, breast tenderness, fatigue, maybe food cravings, sleep issues. They also specifically mention anxiety, stress, breast pain, and bloating again. The notes give a bit more detail on timing, too. Symptoms often worsen about 6 days before the period starts and tend to peak maybe 2 days before.
Okay, a buildup.
Yeah. And the source mentions why women often seek help. It lists things like severe irritability, feeling unable to cope with daily life, physical discomfort that isn't helped by self-care, and difficulties in relationships.
So when it really starts impacting function.
Exactly. The notes also make a significant point that having PMS might increase the risk of developing depression and anxiety disorders later, particularly around menopause or after childbirth.
Interesting link.
And they mentioned psychosexual problems can occur too, loss of libido or dyspareunia, which is painful intercourse. Now, here's a really crucial point from the notes on diagnosis. It's based only on the history, and that symptom diary we mentioned kept over 2-3 months.
Only history and diary.
According to this source, yes, there are no specific physical signs on examination that confirm PMS.
Wow, okay.
And a little caution added in the notes: be careful diagnosing teenagers just based on what a parent reports. especially if you suspect other underlying psychological issues might be going on.
Right. So diagnosis is all about the pattern over time, which leads nicely into investigations. I guess the notes don't list many.
You guessed right. This section in the notes lines up perfectly with the diagnosis point.
Mhm.
The notes are crystal clear. Diagnosis relies entirely on those self-reported symptoms and tracking them against the menstrual cycle with the diary.
So no blood tests for PMS.
They state definitively, no specific lab tests or imaging can diagnose PMS. You can't order a test that comes back saying positive for PMS.
Okay, that's unambiguous.
The symptom diary's role is highlighted again as absolutely key. It's needed for diagnosis and also to see if treatments are actually working, usually tracked over 2 complete cycles.
Right, tracking improvement.
Now, while there are no tests for PMS, the notes do suggest considering some basic physical checks. Things like blood pressure, pulse, maybe a breast exam or a thyroid exam if symptoms suggest it,
Okay.
and potentially a pelvic exam, especially if things like bloating make you wonder about ovarian or other abdominal issues.
Just ruling other things out.
Exactly. The core message from the notes here is, generally, no useful tests confirm PMS itself. You only consider additional blood tests if you suspect an alternative cause, one of those differentials we listed earlier. Investigations are mainly about excluding other conditions.
Got it. Diagnosis by history and diary, investigations to rule out other stuff. Makes sense. So how do the notes suggest managing it? Sounds like it needs a tailored approach.
Absolutely. The notes outline a comprehensive management strategy, emphasizing tailoring it to symptom severity and the individual's preferences. The general approach starts with what the source presents as the foundation: lifestyle modifications.
The first step. What's included?
Regular exercise, stress reduction techniques like mindfulness or yoga, perhaps dietary changes are mentioned, like frequent small balanced meals, focusing on complex carbs. Also ensuring adequate sleep, stopping smoking, cutting back on alcohol, and even suggesting support stockings if aching legs are an issue. These are presented as the first-line things to try.
Okay, the foundational health stuff.
Exactly. Then for symptomatic relief, the notes suggest simple things like analgesics, paracetamol, or ibuprofen for pain, and a supportive bra for breast tenderness. Acupuncture and acupressure are mentioned as things to consider, but the notes explicitly state there's limited evidence for other complementary therapies or dietary supplements.
Good to know about the evidence limitation. What about psychological help?
Yes, psychological support is included. CBT, cognitive behavioral therapy, is suggested for moderate symptoms. Referral, if it seems like it would be beneficial.
Okay, and if those aren't enough, medications.
Right. For more severe PMS, the notes detail pharmacological approaches. SSRIs, the antidepressants, are mentioned first.
SSRIs for PMS.
Yes. The notes say they're effective for both mood and physical symptoms. They can be taken continuously or just during the luteal phase.
Interesting options there. What else?
Options that suppress ovulation are listed. Combined hormonal contraceptives, the pill, might help some women. Transdermal estrogen, like patches, is noted as effective. GnRH analogs are another option. They basically induce a temporary menopause.
Yeah.
But the notes specify these need HRT add-back therapy to manage side effects like bone loss.
Right, managing the side effects of the treatment.
Yeah. Danazol is mentioned, but its use is limited, maybe just for severe breast pain, due to potential side effects. And here's a really important negative point from the source. Progestogen-only treatment is not recommended for PMS symptoms.
Okay, good clarification. Progestogen alone is out.
That's what the notes say. Finally, surgery is mentioned as a last resort in secondary care for severe, intractable PMS, things like hysterectomy or removing the ovaries and fallopian tubes.
Wow, okay, a drastic final step.
Very much so. And the notes wrap up management by mentioning review and referral, checking in after about 2 months, rethinking the diagnosis if there's no improvement, and referring to specialist clinics if primary care management isn't working.
That management section from the notes is really well structured. A clear stepwise approach. Lifestyle, targeted relief, psychological support, then meds, and finally surgery as a last resort for the toughest cases. Shows the range available according to the source.
Moving towards the end, what about prognosis? What's the outlook according to the notes?
Yeah, what can people expect?
The notes state it's generally favorable, provided there's appropriate management.
Favorable meaning?
Meaning symptom relief and an improved quality of life are achievable for most women.
That's good news.
It is. But there's a caveat in the notes. Symptoms might recur cycle after cycle, and how well any specific treatment works can really vary from person to person. And additional info in the source adds that while most women find something that helps, A small number might remain severely affected, with symptoms possibly even worsening until menopause. So mostly positive, but variable.
Okay. And finally, complications. Are there serious health risks associated with PMS itself?
The notes clarify this point well. PMS itself doesn't directly lead to serious physical health complications like organ damage or anything like that.
Okay, that's reassuring.
But the real complications described are the significant impact the symptoms have on quality of life, on relationships, on work, or daily functioning. That disruption is the complication.
The impact on life.
Exactly. And importantly, the notes link severe symptoms back to PMDD, highlighting that if symptoms are that severe, it might actually be PMDD, which needs specialized management.
And wow, that brings us to the end of this deep dive. We've journeyed through those revision notes on premenstrual syndrome, really pulling out the key insights as presented in the source. We covered the crucial definition based on timing, the sort of complex picture of causes and risk factors, the suspected biology, that really important list of differentials, the prevalence stats, what it looks like clinically, the diary-based diagnosis, the lack of specific tests, that whole tiered management plan, the general outlook, and what the real complications are that impact on life.
Considering that significant impact on quality of life and daily function, and that really broad list of potential differential diagnoses, this deep dive based on the notes really highlights just how crucial careful history-taking and that meticulous symptom tracking with a diary are in clinical practice. It's what the source points to for getting the diagnosis right. What single thing really stands out most to you from digging into these notes today?
Lots to think about there. Thank you for joining us for this deep dive. We really hope this helps clarify PMS for you based on the specific source material. And if you are gearing up for the MSRA or you just want to learn more about topics like this in a really focused, high-yield way, there are some great resources out there drawing on material just like what we've discussed. Definitely head over to passthemsra.com. They've got loads more study materials designed specifically to help you prep for those exams. Passthemsra.com. And also, check out freemensra.com. They've got free resources to get you started, give you a feel for the materials. That's freemensra.com. Until next time, keep learning, keep thinking, and keep diving deep.